All right, welcome back, everyone. We hope you enjoyed your coffee break and that you are ready for our next sessions. This time, we're going to be focusing on AI and data, and so how it's going to work. If I can get your attention, please. How this next session is going to work, is that we're going to have a series of 3 presentations. Each is about 15 minutes. After that, we're going to have 3 interactive breakout rooms, and in each of the rooms, you'll have based on the room that you selected at registration, you'll have a chance to dive in deeper into the topic of that presenter's presentation. For those of you who don't have a dot, don't worry, we've got a plan for you as well. So the way we structured it is, you each chose a topic you wanted to dive into deeper, but this way we have opportunity to hear from all 3 speakers before you dive into one topic a bit more deeply. All right, let's now welcome our first speaker, Marie-pierre Revel. She's a professor of radiology at Université Cité and head of radiology at the Hôpital Cochin à PHP in Paris. She is also principal investigator of the CASCADE lung cancer screening study, and she's going to share her professional and personal experience with integrating AI lung cancer screening in France. Marie-pierre, the floor is yours.
So thank you very much, Debra, and to invite me to participate in this first Lung Cancer Europe conference. It's really a pleasure for me and an honor. And as you know, I have not only some professional reasons to be involved in lung cancer screening, but also personal and family reasons. But I'm not here to talk about that, but to talk about AI and the role of AI in lung cancer screening through the CASCADE study that I am leading in France. So what we know is the following. We know that the medical benefit of lung cancer screening is no longer questioned. We have now large randomized controlled trials that have demonstrated that lung cancer screening reduces the risk of dying from lung cancer by detecting lung cancer at an early and curable stage. The risk reduction ranges between 20 and 39% at 10 years, but it is something which is underestimated because at 10 years we have stopped continuing screening for several years, and you need to know that if we stop screening, then the protection fades. And all studies have been demonstrated a higher benefit in women. But most trials were based on double reading by radiologists, which is feasible for a limited number of participants, but is not feasible for large population screening. So just to show that, most trials with NLST being an exception were based on double reading. But now we are in the era of modern AI with deep learning solutions. And in 2019, there was this paper published in Nature Medicine where Google engineers claimed they had developed a solution capable of diagnosing lung cancer more accurately than most human doctors. Very good news, but whether it is true has to be demonstrated because it was based on retrospective data. So this is one of the reasons why I undertook this CASCADE study. CASCADE is an acronym standing for Lung Cancer Screening in French Women using low-dose CT and artificial intelligence for detection. So the research question was the following: to compare the performance of a general radiologist. We do not have enough chest radiologists. So general radiologists trained in screening and using AI as a second reader with a reference, which is double reading. And we had a list of secondary objectives to evaluate the performance of AI as standalone reader. Is it true what the Google engineers claimed? And also to evaluate the performance of AI in detecting coronary artery disease. When we perform a low-dose chest CT, we have also a view of the degree of calcifications of the coronary arteries, and it's a very strong predictor of markers for cardiovascular risk. And this is a very important slide. This is how patients' association can influence political decisions. Because the first year I was not funded. The reason was the study was for women only, and they did not understand why testing AI on a female-only population was relevant. So I admitted that there was no reason for that, but there was a certain reason why I chose to target the female population. I will explain. And I had this letter of support by Lung Cancer Europe that I sent to the Ministry of Health, and it was really instrumental in convincing the Minister of Health to fund CASCADE. So thank you very much. And I had the pleasure to meet Stefania Vallone yesterday. I don't know if she's here, but we were sitting in front of, and I could see her name. Oh, Stefania, thank you so much. So why women? I think this question I was asked like hundreds of times. So the reason is not that I think that we should let men die from lung cancer, of course, but there were at least 4 reasons. First, women were underrepresented in most lung cancer screening studies. The last sentence of the Nelson trial paper published in the New England Journal of Medicine was, more research is required in women. So even though CASCADE is a small study compared to an LST, more than 53,000 participants, a Nelson, more than 15,000 participants, with 2,400 women, we have twice as many women screened by Cité as in the Nelson study. Second, it was to raise attention to the very worrying epidemiological situation of lung cancer in France. It's not only in France, it's also now in most European countries. Now, lung cancer is the leading cause of cancer death as compared to breast cancer, which is 5 times more frequent. And we had that paper published in the Lancet Regional Health in 2022. The statistics from our public hospitals, when they evaluated the proportion of women with lung cancer in the public hospitals in France, that proportion has more than doubled in 20 years, being now nearly 35% in 2020 as compared to 2000. And look, this is extremely shocking. Before the age of 50 years, 41% of lung cancer patients are of female gender in France. When I was a resident, there was 0 women with lung cancer hospitalized in my university hospital. So it's the same age thresholds and screening intervals as for breast cancer screening, and both screenings are based on imaging techniques. And lastly, there's a high benefit of screening in women in all studies. Look, if we evaluate the risk reduction at 8 years, it's 59% risk reduction in women in the Nelson study, although it's with a large confidence interval. So how did we do? So the on-site readers were reading without and then with AI. We collected all cities centrally, and 2 experts were performing independent reading and then consensus if needed, without being assisted by AI. So we have finished our recruitment last year. I will have the first result May the 3rd. And we reached directly the population. And I think it's really essential in screening, not through a medical consultation, directly to the population. So we sent that flyer together with breast cancer screening invitation saying, I'm translating, if you are a smoker or ex-smoker between 50 and 74 years, you could be eligible for lung cancer screening. Call this number or send an email. So why using AI? Sorry, I'm a radiologist. I can't prevent from showing CT images. So what is an early form of lung cancer? It manifests most of the time as a nodule, that kind of anomalies. And I think even though you are not radiologists, not all of you. I can see my colleague Annemiek and Charlotte, but not everyone is a radiologist. It's obvious that there is something wrong here. But sometimes there are more difficult, nodules are more difficult to depict, especially this one, which is connected to the vessel, and it's typically the one where radiologists fail, but not AI, and if there are very small anomalies, only AI will detect. So even the best experts are prone to detection errors. I'm an experienced chest radiologist, and it happened that I missed some nodules, okay? The reason why most lung cancer screening were based on double reading, 2 eyes and 2 eyes, to minimize that risk. And as you can see, this is very difficult because the anatomy is not symmetrical. Here, it's not a vessel, it's a lung cancer. It's very difficult to detect. And it has been shown that the ancestor of modern AI, that was called CAD, CAD stands for computer-aided detection, was superior to double reading. But these first systems in the early 2000s, based on classical machine learning, had limits, a high number of false positives, and a poor sensitivity for detecting a category of nodules that are called subsolid. They are not really dense, and what I demonstrated in this study, that to have only 50% detection rate is absolutely unacceptable in a screening process. It was at the cost of 17 CAD marks per CT, which is absolutely not okay. But now we have deep learning methods, and even for these subsolid nodules, they are detected, they are accurately segmented, so it's okay. So AI avoids detection errors. Here again, this is a case from CASCADE. We have that difficult nodule that was fortunately detected by one of the 2 experts, missed by one of the, I was the one missing this one, but it was detected by AI. So it would not have, in that case, serious consequences because it was a benign nodule with long volume doubling time, but in this other case, again, a difficult nodule, it looks like vessels, okay? It was a growing one. It was demonstrated to be stage 1 carcinoma, missed detection by one of the 2 experts, but fortunately detected by the second one. You understand why we need to be 2 readers. And unfortunately, and so far it's the only case that we had, in that case, detection was missed by the 2 experts. They did not detect this growing nodule that was detected by AI, coming from 100 cubic millimeters to more than 400. And we diagnosed with 1 year delay, which is, fortunately, the participant remade stage 1, but an illustration that even 2 readers can fail. On the other hand, there are AI limitations. Sorry, Google engineers. AI, the current versions do not detect all forms of lung cancer, especially if the dose is very decreased, if it's very noisy image, or certain forms when they are connected to the heart and not surrounded by air, they are not detected, or some bizarre shape, or sometimes lung cancer does not manifest as a lung nodule, but as a nodal disease, for instance. So we are still useful. And lastly, this is not in a screening context. It's in my institution, I have several AI for evaluation. We have a cohort of patients with systemic sclerosis. It's a disease leading to the development of lung fibrosis. And these patients are at risk, at higher risk of developing lung cancer. Unfortunately, if the lung cancer develops inside a fibrotic lung area, even if it's huge, like this one, it is not detected because the AI have not been trained to detect cancer within a fibrotic lung. And it's exactly the same as happened with the Uber vehicle accident. I don't know if you know about that. No. Okay, so this poor lady was carrying her bicycle, and she was not detected as being a pedestrian. It was an unknown object. And the Uber vehicle driver was not paying attention, so the car did not slow down, and the woman was killed. So it's a non-trained context of recognizing a human with a bicycle, like it's not a training situation to diagnose lung cancer within lung fibrosis. So detection with some limits. Now, once we have detected a lung nodule, the next step is characterization, because not all lung nodules are cancers. The vast majority are non-cancers. So the next step is characterization. So there are situations where we know from the morphological characteristics that it's very likely to be a lung cancer. We have some very limited criteria where we can say we are formal, it's benign, but the vast majority, they are morphologically indeterminate, okay? So some vendors have developed solutions telling us this one is a lung cancer. The problem is, how can we, as radiologists, validate this AI, since we do not have that kind of tool? How can I control? How can I trust? For detection, I can say it's true or it's wrong. For segmentation, I can say it's okay or non-okay. But for a prediction, it's not possible. And it's our full responsibility as radiologists for the conclusion. We cannot, blame the AI. It's our responsibility. So fortunately, and the reason why I'm relatively reluctant to trust is this paper. 8 lung cancer prediction models failed to generalize well outside their training cohort. Very good results on their training, and not so good results on an external data set. So this is for the time being. I'm not telling that it's forever. Perhaps it will change, but for the moment, this is the situation. So fortunately, we have validated, reliable strategies once we have detected a lung nodule. One is to perform a short-term follow-up after 2 months, for instance, to detect growth. Hello? Did I do something wrong? No.
Perhaps while we troubleshoot, I think it's our projector. There's a connectivity issue perhaps with the projector, if I had to guess. Maybe we'll get you to just give us your closing remarks for your presentation.
Okay, so I can, sorry for those things. Maybe go ahead, Mike, just to finish the presentation. Okay. So we have validated strategies. Is it?
It's on. No, it was on.
Which number? No.
Hello.
Yeah, okay, closer. Like short-term follow-up or PET-CT or performing a biopsy to avoid futile surgeries. Oh, it's working again. So, but AI is narrow, and outside, in addition to lung cancer, there might be some relevant findings to report, like this CASCADE participant, a retired nurse, fully asymptomatic, she had active TB, and that case, I'm not a fan of looking outside the lung, but in this CASCADE participant, I noticed that the right kidney was not okay, and she had a lymphoma, and she was treated successfully and now is okay. So in conclusion, AI plays a major role and will facilitate implementation, because I think I will be able to demonstrate that we can get rid of the second reader. But it currently does not detect all forms of lung cancer and has not been trained to detect other important anomalies. Just for you to know, This is, I was leading one of the pilot of the SOLAS project. SOLAS is strengthening lung cancer screening in Europe. And we know from yesterday that we have been granted for SOLAS Plus, where we will be evaluating AI. And this is, and just to show that I developed an obsession for CASCADE. Thank you very much.
Please give it up for our speaker. Thank you. Thank you so much, and I think we are just as excited as you to get your results on May 3rd, so we'll stay tuned for that. Next, we have the pleasure of having with us back on stage Elena Petelos, who is Senior Oncology Researcher and Health Systems Expert, AI and Digital Health. She's going to tell us about how AI innovations get integrated and may reach patients in practice, drawing from her experience as President of the Global Health Section of the European Public Health Association, as well as her experience as co-chair of the Real World Evidence and AI Interest Group at HTAi, which is Health Technology Assessment International. Elena, the floor is yours. The timer is over here.
It's good, thank you. So I couldn't be happier to follow up on a presentation focusing on women. So I wear different hats. Men have higher incidence of lung cancer, but in non-smokers, we are higher. And global health is quite interesting because you think we have not the best deal in Europe, but in Asia, they're underrepresented by 60 to 80% in detection and in trials. So of course, that's scary numbers. So very happy to see what was there. I have to say that I do wear many different hats. If one of them is useful in the presentation, please reach out. And of course, I do belong to different entities. Some were mentioned. Views are subjective. Because the topics are becoming somehow very controversial. Health is becoming very controversial. So there's been, the slides are there. I tried to do graphics. Thankfully, ChatGPT was obliging, although slow. Mostly for you to be able to navigate a few things. I think some of the things you heard us discuss earlier are very well known to you already. Some other things that are coming up, like the HTAi regulation, health technology assessment, and what it is, what HERA may be doing, which is a new authority in the European Union, which will be focusing on joint procurement. And already there's some discussions for what we call critical medicines, but also some of us have put forth of why also not negotiate for oncology or very innovative or very expensive treatments. So some of these things are not very well known. So if there's something that you're not familiar with and we do not tackle within the next 5-10 minutes, kindly reach out. More than happy to answer. Or please use the Slido we have. And of course, we have a session afterwards that we will be discussing these things a little bit further. So performance was mentioned. Performance is improving. I think you may be, I'm going to have a guess because we're focusing recently on histopathology. FDA recently opened its database for all AI medical device-enabled, AI-enabled medical device technologies. Can anyone guess when the first couple were approved? I mean, of course, they did it retrospectively, but they also look at machine learning and AI. So any guesses how far back? Just shoot far away with the most crazy number that comes to mind. Anyone? 2016? No? Go back? 2000? No. 2014 was the first lung, by the way, which is still out there. It is for density, but further back, it's 1995. 1995, and it's cytology, it's PUP tests. One went down because there was never uptake. They were both working. The other one was bought over. It's still out there in new forms. Of course, there was automation, but I think the challenges for AI and innovation, medical informatics and so on, have been there for a very long time. It's just that now are becoming very all the rage and very visible. And of course, AI has potential, but also has very concrete risks for patients and data sharing. And I think you will hear more about it later on from the next speaker. For me, I think it's important to emphasize that we have a complex ecosystem when it comes to reaching access, ensuring access, safeguarding access, and the concept of whether something is performing well for its function, its design, and whether actually it is of value to patients and of value to societal level, it's two different things. And you would say if it's of value to patients, why could it not be of value necessarily to societal? Because if you have a very, very high cost to determine that, then you get cases where you don't have access. And a very old example, but maybe known to some of you, was crizotinib many years ago. We knew it was working. But Veneto at the time calculated how much it had to spend to test the population. It was a regional decision within Italy, and it did not allow at the time, and I'm talking more than 15 years ago, or almost 15 years ago, it did not allow reimbursement. So AI has also some new things to offer. There are some aspects of false negative testing, false positive testing that it can inform. But the biggest challenge that we're seeing at the moment is generalizability of evidence. And I think a little bit the previous speaker touched upon that. We have not one Sybil, we have over 27 Sybils out there at the moment, but they function well with data sets that they're trained on. And then, of course, the representativeness in terms of data sets goes to where you have pilots and how the pilots are scaled up. And in terms of this, even if you do have meaningful output, how do you actually integrate it into care, and how you finish a very good horizon project, which many of us have finished, how does it become a second project or actually part of routine care? And this is a very big challenge, and fits back to the discussion of, okay, the European Union funded something, where does it go later if you want to make it part of the system? To my experience, and I've gone from clinical to research, and everything that was of interest I kind of learned or tried to work in, you tend to, on every step of this journey, you tend to kind of drop a few patients out. So you start very nicely by research and validation, and you circumscribe a very specific population. For targeted treatments, you know, you go, maybe METX14 that was mentioned, maybe GFR, which is, of course, now very well accepted, maybe about 11 very well accepted biomarkers. Then you go for regulatory approval, which is focusing only on whether something is clinically effective or efficacious, if you like, for clinical trial setting for the specific population, which in trials was, by the way, mostly healthy and selected and not in real conditions and so on. And of course, you're assessing only that particular drug, that particular modality, not the entire care the person is receiving. So some people are dropped there. And then you go to HTAi, which is looking which line of treatment you may have and which other comorbidities you may have, and will you be up the mountains of Northwest Greece able to travel? Because HTAi, I don't know how many of you are familiar with HTAi. We've mentioned so many times the HTAi. The HTAi regulation is not about HTAi per se. It's actually joint clinical assessment. The member states are supposed to come and complement with HTAi. But HTAi is not the same as regulatory approval because it's looking at the clinical aspects, but also looking at the organizational delivery of care, at ethical aspects, also identifying who may be harmed from treatment. And this is a very big thing because we do see this. I can mention at least one example. It's not from lung, it's from ovarian, where we've seen wild type not benefiting, whereas BRCA benefiting. And we didn't know that until the first big meta-analysis this summer for Zasvla. And even on that stage, you drop a few more patients in terms of access. Yeah? And then you go to reimbursement, which you heard already a lot about. And reimbursement, of course, it's regional, national priority, depending on how devolved you may be in a country. Very often is completely decoupled from innovation for valid reasons. And then you go to clinical adoption because you have to get it prescribed. And even if everything is in the mechanism, somebody has to actually lead the patient to that treatment modality. And I think we already know from practice that there is a lot of heterogeneity, even within the same country, even with the same region, even within the same hospital setting. I mean, that is not coming from me, it's coming from the evidence base. And then finally, of course, you may have a patient which has different preferences. And thankfully, there is a very large body of research emerging with patients, which is capturing the patient experience journey. You will hear more and more as we go forward the term PED, patient experience data. That is not to substitute the rest of the outcomes. That is to complement and also to generate more rich experience data sets so that the AI can actually factor in other aspects. So, I mean, if you're a cancer patient, you know what it means to have an infection and to be hospitalized for it, or to have to make multiple visits for monitoring, or to suffer other adverse events that, or indeed, in some cases, and this is also not recorded very well, if you have, to link to before, very good cardiovascular health, no comorbidities, to have much, much better outcomes than what you were prepared for. So both sides are not captured as it could be and as they should be. And then, of course, there are other aspects when it comes to AI. AI cannot tell you whether somebody wants to live an extra year with bad quality of life because they want to see their children or grandchildren grow up, or whether somebody wants to have very high quality of life but not suffer. So it does not, the technology may be there, we're assessing it, but you cannot take away these critical components. There's a lot of confusion about that. And I'm afraid that we inordinately are focusing on that part rather than on the rest, including in terms of the HTAi regulation. The member states are running to implement it. That's an opportunity for people to be involved, patients to be involved, but they're not running to complement the rest of the pieces, which means whatever they bring in the country may not be relevant for them. Then, in terms of the last mile of the problem, for patient benefit, let's assume that everything goes well and you have everything there. So you have strong evidence, you got regulatory approval, look on the bottom, look on the treatment. You got HTAi, you got reimbursement, and diagnostically up, there's nothing happening. Or you have to send to California and it will take 2 weeks, or you have to a centralized lab. Yeah? You are in trouble, because 4 or 5 weeks down the road, there will be nothing there. So in terms of real-world barriers, even if you have treatment, great, you still need diagnostics. Even if you have both, availability and access and ultimately accessibility are not necessarily there. And then, of course, you do not actualize, you do not affect patient benefit as it goes, so you have a loss. In terms of uncertainty, of course, critically, the uncertainty is something we have to factor in, and particularly for lung, as I said, I think I've mentioned a couple of times today, we have metastatic aspects and we have line treatment aspects that are highly differentiating. So, of course, when are you testing and how are you testing and how are you retesting? It's quite complex. And ultimately, a clarification, because I hear screening, I am also a public health specialist. Screening is not referring somebody to test. Screening is testing population, mass population testing. So opportunistic testing, also very nice, other modalities, yes, but screening necessitates guidelines to a national action plan, critical. So I think I'm still on time, very much, but yeah, it's good. So yeah, no, because Anna is stressed, I think, because yes. So of course, in terms of data sets, there has to be trust and there has to be provisions for the patients to be willing to share their data. And traditionally, when we say data for AI, of course, people think I will give the information about how I live, I will give it. But of course, more and more we're discussing samples, we're discussing biological material, and we're discussing processing of it, cloud, and potentially also along with it, other types of data. For AI purposes, we are seeing, including in the medical informatics community, very high willingness to share from the people that are cancer patients. I think it started, sorry to the men in the room, very strongly with women in breast cancer. The moment BRCA became visible, because they had the daughter in mind, and they really wanted things to change in that direction. But I think it's going also very strong in other modalities now. And generally speaking, it's often seen as a block, whereas actually it represents an opportunity. There is an aspect which is also often neglected, that even if you try to implement, you have scale-up of AI, the learning curve for the personnel can be difficult. So it's not only to have AI tools in place, it's how you train the healthcare professionals, and how potentially, if you involve them in real-world data selection, you do not burden them further with that. In the global health settings, you actually seeing what we see even in high-resource settings that are under pressure. So the doctor or the nurse or the other personnel that is handling these tools are being asked to do more and more tasks. I think since we are in Austria, and we actually had a session on this last year with the ministry here in the primary care forum, there were 11 or 10 systems that they were asked to input data for different patients at the primary care level for cancer patients, which is an extremely high number. of duplication. So if you need 5-10 minutes to see the patient and 15 to 20 minutes to participate in other things, somehow I think the level of error and the level of frustration abrogates or sort of deletes the benefit. And then, And then, of course, an example of a good, if you like, practice. You see there's a lot of activity happening in terms of clinical guidelines, how we will handle AI and so on, which is superb. But how this translates in terms of resourcing and so on is not quite there, including particularly for lung. But you also have examples which could be innovative in the sense of we are seeing where there is a national cancer plan, an explicit mention in terms of access and equality, inequality, you get to have more population-wide consideration for outcomes. I think this is one of the few cases, it's England, but still, they actually mention that they want to have greater precision and standardized techniques for inequalities, to tackle inequalities. So this is something, let's say, new, and I think, I'm hoping that Europe will go to this direction. Yes. And then, of course, going back to the value-based care, at the moment, we have no mechanism in the HTAi regulation. We are assessing centrally with the HTAi coordination group, we are assessing new treatments coming in, but we're not assessing them combined, so we're not assessing the diagnostic modality combined. This remains decoupled. There are provisions to do diagnostics and to do medical devices in AI and so on, but it's not the path that you're assessing, and it's not the access that you check if it's successful or not. At the moment, in terms of success of the legislation, the report that has to go to the parliament is whether the member states implemented the legislation, and what is being assessed is the innovative for the ones that the industry is submitting dossiers. Perhaps this is also a challenge for the dossier for the industry, because usually the companies that are developing the treatments are not necessarily the companies that develop the assays and the diagnostics or the platform. And then just a final consideration. There's the aspect that you heard mentioned before. So we have a lot of issues that never scale to routine care. We're about to publish, we haven't published it. It's for histopathology, the focus is histopathology and radiology, because funnily enough, for practical reasons for AI, these two specialties are higher up at the moment than oncology in relation to oncology. Better awareness, exactly because of diagnostic modality. And where there has been no uptake, or where the effort has had to be left aside, is because there was either no trust or no organizational capacity to absorb, even when there was access. I think it's one more. Yes. So I will only be another 30 seconds, Anna. So this one is to know that up to now we had urban to rural disparities, but now we're seeing where there are trust relationships with physicians and good primary care. Interestingly enough, people are referred much faster. So sometimes the specialized care, it's very much necessary, but it's certainly not sufficient to provide for people. And an oncologist cannot be expected to be a coordinator of care across all the multimorbidities an average patient will have. So we're missing the coordinator of care. And the opportunity, I think, for patients is to be able to co-design not only the clinical trials, but their care in general. There is no specific provision for that, not in relation to AI, but in general. But AI is an opportunity at the moment because we're harvesting it. And there are, this is quite resistant to. Okay, it doesn't like to look there. So, okay, let's go quickly. Do you want to try? Because I certainly. Yes. So, in terms of accountability, thanks. In terms of accountability, now we're moving to system-level accountability and implementation at scale. So, for that mechanism to work, it has to go to a different level. So it's not the patient in the HTAi procedure or the oncological or lung cancer patient in the decision for making a treatment. Is the patient as part of the system for making decisions for paths and for integrated care. That is starting to emerge in 2 or 3 European countries. particularly because we have aging population, but it's really missing there as our predictive algorithms for who is most at risk. And then last but not least, a little bit optimistic to close this before suggesting something for the patients. We have the European health data space. There are also agreements with countries like the UK or Japan or, for data exchange. This is an opportunity, and we see it coming because there will be a gateway for data, and there are also new projects coming up that will be looking at electronic health records, going backwards as well to identify signals, who may be most likely to benefit not only from genetic predisposition or biomarkers or even histopathology, but also in terms of accessing care, who should be prioritized and so on. So ultimately, to have equal care, you need to prioritize people that normally may not be accessing tests rather than just treatments. And I think, yes, that's my suggestion, if I may say it. So in evidence-based medicine, you do have patients at the center. That is often forgotten. This is a suggestion on where I personally think we can have patients at the moment. I do think it's an opportunity because the countries are at the moment putting their mechanisms in place for HTAi, for access, and I think in some cases for national action plans for cancer, including for specific modalities, for screening and so on. And as when it comes to AI, we have the factories, which is a piece of legislation that is not coming from health, but you can have your local member states or MEPs starting to discuss that in this respect. This is not happening per se yet. We have the AI office coming to the EMA, and we're starting to discuss a few things, but it's very early days and very few patients there, so it would be very nice to see more lung cancer patients too. And I think that's it. That's my blueprint. I hope it's clear. And yeah, hopefully, I'm sorry, Anna, I did not oblige. I was on time rather than overtime, but yeah, hope it helps. Thanks.
Thank you so much.
Thank you so much, Elena, for this great presentation. And I especially appreciated that you ended by mentioning federated data, because that is the topic of our next presentation. So our next two presenters will be jointly presenting, and they're both researchers at the IDERA project, which is a European research partnership whose goal is to develop a federated data platform to facilitate access and analysis of health data across Europe. And so without further ado, please join me in welcoming them. We have with us Nadja Kartschmit, who is a researcher at the Medical University here in Vienna. She's also a nurse. And Omnia Bilal, who is a researcher at NICE, which is the National Institute for Health and Care Excellence. They're going to be talking to us about the European health data space and how it can improve lung cancer care in the long term. Over to both of you.
Tech's working. I will try and keep this quite brief, but thank you to the Luce conference organizers for having us here. Thank you all for being present as well. Nadja and I are very excited to talk to you about real-world data, real-world evidence, and I'm very happy that we're following from Elena's great presentation about evidence generation and bringing it back to the basics with health data. So for today, we'll be talking to you a little bit about what health data is, what it means to different stakeholders or different groups of people, what is this data already being used by, how are these different stakeholders using this type of the health data, and then where are there opportunities for change, where are there opportunities to really drive the use of health data to improve evidence generation and ultimately, improve healthcare delivery across the systems, and then bringing it back to the patients, and particularly lung cancer patients, what's in it for them with this health data and sharing their health data, and where we can all get involved, where we would need your input as well. So, what is health data? In short, it's any information. Oh, thank you. Yeah, perfect. It's any information about your health or care. So think about going to your local hospital or going to your local doctors, your appointments there, any prescriptions that you pick up, any follow-up appointments. So really any data that makes you in the eyes of the healthcare system. And there's a lot of different types of data there. It's also referred to as health data, but there's a lot that can be done with this data. So different people, like I said, will have different uses for this type of data. Different groups of stakeholders or people have different uses for the health data. So for example, you have your researchers who really take this data from the healthcare system and it helps them develop their clinical studies. It helps them identify where there are gaps within the healthcare system and what they can do within their research to fill those gaps, essentially. You also have your clinicians who take the data or take the evidence that is developed by the researchers and use it to inform their practice, also using observational data that they have from within their practice, from their patients that they interact with, to inform practice and shift practice for patients there and also improve outcomes for the patients there. And ultimately, going a level above at a national and sort of governmental level, you have your politicians who use evidence generated from the research, calls to action generated from the researchers and clinicians and sort of local health systems to improve and also to approve policy, and approve legislation across the system. So shifting things at a regulatory level from the top down. Alongside politicians, you also have your health authorities who, like Elena referred to, they are heavily involved with your regulatory and approval decisions about whether a treatment is safe, whether it's effective, whether the treatment is of value not only to the patient but also to the healthcare system. We're talking about money here. So ultimately, all of these different groups of people or stakeholders are here and exist and work collaboratively to ultimately benefit the individuals, the patients, or the citizens like you and me. There, got it work. So, bringing it back to lung cancer, what can be done? So specifically within the lung cancer use case, health data has been used to prevent lung cancer historically. So researchers and clinicians found the exposure to a certain gas, radon, increases the likelihood of lung cancer. And with that, they were able to generate evidence that was then pushed upwards at a policy and legislative level that improved the monitoring and also the adjustments for radon gas level at the local environment. So ultimately for the patients and for the individuals, what this has done is that it created healthier populations, but it also lowered the burden on the healthcare system. So a benefit all the way from the top down. Next, with lung cancer as well, health data has been used to diagnose lung cancer earlier. There was studies, preclinical research indicated that a certain gene increases your susceptibility or likelihood of you developing lung cancer. With that information was passed on to local health authorities where screening and testing at a population level was approved, and therefore within that coming down to the patient or the individual, there was improved prognosis for them, better treatment outcomes, and ultimately population level, population healthcare, population level, sorry, that's a tricky one. Healthcare at population level was improved. And then the last use case with lung cancer, go back to drug discovery, right? But within that researchers found that a treatment can work for an additional indication. I'm talking about breast cancer treatment here that was found to have an additional benefit in lung cancer patients. And this was something that was picked up observationally in clinics and in hospitals. And what was then done was this information was taken up to local authorities that had already approved this certain drug for breast cancer patients. However, they were able to expand the indication and the approval for lung cancer as well. And with that, patients were able to get access to this treatment faster because it was already approved, it was already in the system, and ultimately that also saved costs for the healthcare system. So lots of benefits all around, and like I said, health data is being used by the system, but not consistently, unfortunately. So what are the problems? Most of the problems are operational, so they are to do with variations in how the data is stored, where the data is accessed, who gives their data, who doesn't want to give their data, and where where there may be differences in how the data is used between one stakeholder to another. So researchers may hold a certain data set versus local health authorities, and what do they do with that? How do they interact there? So there are mainly operational differences. There are jurisdictional differences as well. Different countries have different laws for the use and storage of health data. And also bringing it back to the patient and individual level, there is this underlying variation in how patients trust and also feel like they can have a say in how their data is used, accessed, and stored by the health system, right? So where is the benefit for me at an individual level? These are all issues that are happening across the board. So thankfully, something is being done about it. The European health data space is set to revolutionize data sharing, data access, not only at an individual level, but also kind of at a policy level further higher up. And also projects like IDERA that me and Nadja are involved with are set to also facilitate with the implementation of the European health data space, facilitate data sharing, but also overcome some of the challenges and the barriers around the inconsistencies with data sharing that I outlined in the previous slide. So with that, I will hand over to Nadja, who will talk to you a little bit about the European health data space.
Yes, thanks, Omnia. So I think so we have heard the term European Health Data Space quite several times today, but as not all of you might be too familiar with it, I just want to introduce you to what it is. So first of all, it's a legislation that came into force last year in spring, and sets out the legal rules on how to share data in Europe using this EHDS framework. So of course, data can also be used using existing frameworks or also frameworks such as IDERA where we're working in. But it's just to simplify the process and to make it faster and to make it also equitable across Europe. It also sets some specifications regarding the technology. So in the EHDS there is already also second legislation where this will be then defined in more detail. So how should the technology look like so that data sharing is actually safe, and that is all the highest standards regarding data security are also implemented. So as I said, last year it was and it entered into force, the legislation, and now we're in the preparation phase. So the member states are getting ready for the EHDS to be then used for research in 2029. So it is expected that then the first data can be used for research purposes, but also for statistics, but also for policy making, and also can assist HTAi and regulatory bodies with making their decisions. And in 2034, also other countries can join that are not member states. So how would this work in the EHDS? I will just briefly provide you with the pathway, and we also believe that the patient voice should be included in the whole process. So let's assume a researcher, but also a pharmaceutical company, so it can be public, it can be private bodies, but it can also be public authorities. They can apply for access to this data. And very importantly, the legislation also introduced an opt-out. So if a citizen does not want that their data is used for these purposes, like for research, policy making, but other also purposes that I mentioned in legislation, they have the option to say, I don't want this, and they can opt out. But this will be introduced at national level, so not harmonized within the member states. So there is an access application, and this access application will be assessed by an authority. So this is an authority that each member state will establish, the so-called health data access body. And it is also the case that only certain users are allowed. So it's not allowed to use the data for marketing purposes, for anything that can harm a population or an individual, and can cause also or discriminate against the population. So then when this application is granted and it is approved, the researchers, the companies or public authorities cannot see personal data. So the data is anonymized or pseudonymized, and are kept in safe places where that it can also only be looked at there. So these data cannot be downloaded. What can be downloaded are only the aggregated results. And the authority that grants access to the data also makes sure that no data is downloaded that is potentially can be re-identifiable or to an individual. And then it's also the case that the results have to be published. So you cannot analyze the data and say it's not the result that you expected, so you just leave it in a cupboard and that's it. So you have to publish the results. And this evidence also can then be used in regulatory decisions, but also in HTAi decisions, and also in funding approval decisions. So yeah, this is just you would call that then real-world evidence that you generate with this real-world data. That has also advantages over using only clinical trial data. So we need both actually to make good decisions. This was the HTS. I'm talking also a bit about IDERA because there are some overlaps, and we try to facilitate the implementation of the EHDS by our learnings, but also we want to align the project as much as possible to the EHDS framework. So we started our project 3 years ago, and we have still some years to finish the project. However, we try to develop a sustainable solution that goes beyond the project time. So we want to offer a framework for data sharing that is will not end by end of March 2028. We have 32 public and private partners from 10 countries in Europe, but also we have one from the United States that supports us. And it's a huge project with a lot of researchers involved, with over 40 million euros of funding. And we are funded by the Innovative Health Initiative joint undertaking. This is co-funded by the European Union. It is also part of the Europe's Beating Cancer plan that we heard about before. So what are our aims? Our aims, if you see this, are quite similar to the HTS ones. So we also try to build a technology to share data that is safe. And we also use a similar approach. We use a federated approach. Just for, if you're not familiar with this word federated, what does it actually mean? So the data stays where it is. It does not travel to one place to another. It's not downloaded or referred to via other ways. It stays where it is. So if it's at the hospital, then it stays at the hospital. And we use a federated approach to share these data, and only the aggregated results will leave these environments. And we also use like this approach from the EHDS, where this data is only analyzed in secure environments, the safe places I just mentioned. And what we also do is to establish clear rules for how things should work. So the governance framework is also developed within IDERA that is in line with all the European and national legislations and regulations, such as also the General Data Protection Regulation. But what we also do is provide recommendations to decision makers, and that's where Omnia and I are very much involved in. So we talk to HTAi bodies, we talk to regulatory bodies, we talk to patient communities, we talk to all the stakeholders you have also just seen on the previous slides, to make this work in practice. Because we know that there is a barrier from research project to actual implementation and uptake, and we also heard it in the previous presentation, that you lose a lot of patients in the way, and we try to bridge this gap. So we have several use cases. IDERA is focused on lung cancer, and we want to capture the whole pathway. So we have also AI and machine learning models that we develop within the project using real-world data from hospitals, from electronic health records, from CT scans, but also we collect prospectivity data from wearables and an app that we have developed within the project, where we also track the patient-reported outcomes. So how is the patient actually doing? Also to be able to stay at this is what we do. So we develop artificial intelligence models to improve the diagnosis so that it's earlier, that the treatment is personalized and optimized for the patient, and also that the health outcomes improve in the end. So how does the two work together? So as I said, we try to align the legal framework, so the laws, the rules, also the organization, the policy with a big P, but also with a small p on the organizational level, the hospital level with the EHDS, but also the technology. So yeah, yes, it's working. So we try to align these two with the EHDS framework, and want to also share the knowledge and the lessons learned. We have gained this knowledge throughout the 3 years of the project for the implementation of the EHDS, and also try to facilitate the EHDS implementation, see where we can support also small hospitals, for example, and how to they have to meet some requirements under the EHDS and how to do this. The other way around, also, we try to prepare the project for the EHDS once it is fully implemented, so that our framework aligns with the EHDS. So why do we need data? I think it is very important that we use data generated in Europe for research and innovation that will then benefit patients also in Europe. Because based on these data, as we already have heard, governments and health authorities make decisions, and we should make sure that the data, also when we train artificial intelligence models, is from the European population, where we want to make some, when we want to make decisions for the European population. So I think it's very important to state here that we cannot generalize findings from other countries to European population that easily, so we should use the data in Europe that we have. Yeah, I think this is the last slide. So what's in for the patients? With data, the prevention of diseases can be improved, but also once you have a disease, the treatment can be improved. You can receive better care because you know what works, you know what doesn't work, and you need data for this. And in the long run, we hopefully as a society will have longer, but not only longer, but healthier lives. So in IDERA, we try to engage as much as possible with patient and patient communities. So that's why we also need your input, because we believe that EHDS will not be successful if the patient voice is not heard and not adapted. So it also IDERA, it will not succeed if we don't include the patient communities. And therefore, we conduct workshops and public consultation, but also individual interviews. And we would like to welcome you to approach us if you're interested in this, because we would really like to talk to you about your concerns about data sharing, about how solutions may look like in practice, how this should actually work in real life then, what is in the legislative piece. And therefore, we would like to invite you to go to our website, and also, if you like, write us an email at communications@idera.org. And with this, I would like to thank you, and we are looking forward to the breakout sessions and discuss this further with you. And if you have any questions, you can also ask in the breakout session.
Thank you so much.